Hello, and welcome to the New York Presbyterian Hospital, Weill Cornell Medical Center Kidney and Pancreas Transplant Program. Today we are going to introduce you to our transplant program and review the basics that you need to know about transplantation. You will find detailed written materials in the packet you received earlier today. The information we are about to review is covered in those materials, so please do not feel that you have to take detailed notes during this presentation. Please do write down any questions that arise as you are watching, and your transplant coordinator will answer them later today. This presentation is also available on our website for you to view at any time. Thank you for your attendance. We hope you find this presentation interesting and informative. The first topic we will review is eligibility for kidney transplantation. People who need a kidney transplant have a problem with their kidneys that has led them to needing dialysis or a transplant to survive. People develop kidney failure for many reasons. The most common causes of chronic kidney disease leading to transplant are diabetes, high blood pressure, diseases that affect the glomerulus, which is a part of the kidney that filters the blood, and polycystic kidney disease. In order to be eligible for kidney transplantation, you must be healthy enough to undergo major surgery, which requires general anesthesia. Because of this, people who need a transplant should not have severe problems with their heart or lungs. Because of the medication used to prevent rejection of the transplant, patients cannot have current or recent cancer, although there are a few exceptions. Patients must also have a good track record in attending dialysis and taking their medications, since adherence before transplant often predicts a patient's adherence with the medications and follow-up visits required after the transplant. Patients must have sufficient insurance coverage to cover the transplant medications and other follow-up costs, since these can be expensive. The degree of kidney failure that a person has can be determined by an equation that calculates the glomerular filtration rate, or GFR. This number gives us an idea of how much kidney function remains and helps to guide your placement on the waiting list and/or scheduling of a living donor kidney transplant. As you can see in the graphic on the right, in the yellow section, people with kidney disease have a GFR between 15 and 60. Patients with kidney failure have a GFR of 15 or less, as indicated in the red section of the graph. Patients usually require dialysis when their GFR reaches 10 to 15. However, patients can be listed for transplant once the GFR reaches 20 or less. This enables us to perform what we call preemptive kidney transplantation, which means getting a transplant before needing dialysis. This is an important option since it is well known that people who receive a kidney transplant before needing dialysis do better after their transplant. Next, we are going to review the different types of living donors that can donate one of their kidneys to someone needing a transplant. The first are living related, which means the donor is a blood relative of the person needing the transplant, such as a parent, an adult child, a sibling, or an aunt, uncle, or cousin. The second are living unrelated, who are people you have a relationship with outside of blood relatives. This can be a spouse or partner, friend, neighbor, co-worker, or other acquaintance. The third type of living donors are altruistic donors, who are people who want to donate a kidney but do not have a specific person to donate to. These donors, also called non-directed or Good Samaritan donors, are often matched up with people who do not have a donor or who have a donor who is willing but incompatible. We will now review the different types of deceased donors. The first type of donor is a standard criteria donor, which means the donor was under the age of 50 or were between the ages of 50 and 59 but were relatively healthy. Expanded criteria donors are older and often have underlying medical conditions. All donors age 60 and above are considered expanded criteria donors, as well as donors age 50 to 59 who have at least two of the following criteria: a history of high blood pressure, death due to a stroke, or evidence of suboptimal kidney function at the time of death. Patients waiting for transplant must express their willingness to receive a transplant from an expanded donor by signing a separate consent form. However, you do have the right to refuse a transplant from this type of donor without risk of penalty. The third type of deceased donor is a donation after cardiac death donor. These donors have their life support removed in the operating room prior to organ donation, which can lead to an increased chance that the kidneys will take longer to wake up after the transplant. However, these organs do tend to function very well once they recover. There are a few other special situations regarding deceased donors that we would like to review. Keep in mind that the decision to use the types of organs we are about to discuss is made on a case-by-case basis, carefully balancing the risks and benefits. Our own center-specific results using these types of organs has been excellent, so we continue to offer these types of organs as a valuable resource that can help shorten time on the waiting list. Donors with hepatitis C infection are considered only for patients who have hepatitis C infection themselves. In addition, these organs are limited to patients who have actively replicating hepatitis C and are not for patients who have successfully cleared the virus. Centers for Disease Control high-risk donors are donors who have risk factors for infections such as HIV or hepatitis C. The risk is due to donor behaviors such as high-risk sexual activities or IV drug abuse. Although we test all donors for these types of infections, there is a small chance that the infection is too recent to be detected with standard tests. Again, all of these donors are considered on a case-by-case basis. The person the kidney has been offered for is informed of the risk, must agree to receive that organ, and has the right to refuse without penalty. Organs from pediatric donors can also be used for transplantation. Depending on the size of the organs, patients receiving a transplant from a pediatric donor may receive one kidney, or more rarely might receive both kidneys. Although these organs are smaller because they are from children, they do grow over time after the transplant, usually reaching adult size. When learning about transplantation, you will hear the term compatibility used frequently. There are several types of compatibility that are important. The first is blood type compatibility. This chart shows which blood types are compatible. As you can see, someone with blood type A can receive a transplant from a donor who is type A or type O. A person with blood type B can receive a transplant from a donor who is type B or type O. A person with blood type AB can receive a transplant from anyone of any blood type. These people are called universal recipients because of this. A person with blood type O can only receive a transplant from a donor who is also type O. As you can see, a donor with blood type O can donate to anyone, which is why O donors are called universal donors. The second type of compatibility we look for is HLA, or antigen matching. Antigens are unique markers on the surface of our cells that we inherit from our parents, and which help our immune system to recognize foreign cells, such as those from a transplanted organ. There are 6 antigens that we try to match in transplantation, although thanks to the anti-rejection medications available today, matching is not critical to the success of transplantation. Although you may have heard that a perfect match kidney, a so-called 6 out of 6 match, does better than other kidneys, you should know that less well-matched transplants also do very well, and often there is no match between the donor and the recipient. The last step in assessing compatibility is to perform a cross-match. A cross-match is a test where the blood of the recipient and donor are mixed together to see if there is a reaction against the donor. We want you to have a negative cross-match, which means there was no reaction. If there is a reaction, which is called a positive cross-match, it means that the recipient has developed antibodies against the donor. Antibodies develop when people are exposed to genetic material of other people through blood transfusions, prior transplants, or pregnancy. When antibodies are present, it does not mean that the transplant cannot occur. It just means we have to see how strong the reaction is, and then see what other options may be available. There are a few options available when there is a blood type or cross-match incompatibility between a donor and a recipient. For a positive cross-match, there are medications and a treatment called plasmapheresis, which can decrease the amount of antibodies and possibly allow the transplant to occur. Similar to positive cross-match transplantation, blood type incompatible transplants are also sometimes possible using similar medications and treatments. If these treatments fail to reduce antibody levels sufficiently, patients do have the option to wait for a deceased donor transplant or to participate in donor exchange programs, which we will discuss next. When a donor and recipient pair are not compatible due to the previously mentioned reasons, the donor and recipient can consider joining a registry of other incompatible pairs. Within these registries, computers are used to match compatible donors with recipients. This is known as kidney paired donation, or KPD. Logistical issues are worked out and the surgeries are scheduled. Donors and recipients are often at different transplant centers, sometimes on opposite coasts of the United States. At Weill Cornell, we have worked with the National Kidney Registry to help facilitate these types of transplants, and we have transplanted over 75% of the incompatible pairs that we entered into the registry. An additional benefit to kidney pair donation is that it can reduce or even eliminate the need for additional medication therapies that would have been required for a cross-match or blood type incompatible transplant. Here is an example of the kidney pair donation which occurred at Weill Cornell on Valentine's Day of 2008. As you can see, an altruistic donor kicked off this chain of transplants. As mentioned earlier, an altruistic donor wants to donate but has no specific recipient in mind. The altruistic donor gave her kidney to recipient number 1, a woman whose husband was cross-match incompatible. Recipient number 1's husband then gave his kidney to recipient number 2, whose husband was also cross-match incompatible. Recipient number 2's husband then gave his kidney to recipient number 3, a 5-year-old boy whose father was blood type incompatible. Recipient number 3's father then became a bridge donor, who kicked off another set of transplants several months later, thus perpetuating more transplant chains. It is important to note that kidney pair donation is not limited to incompatible pairs. Even if a donor and recipient are blood type and cross-match compatible, they could choose to enter a registry for the purposes of kidney pair donation. As an example, a 75-year-old man needs a kidney, and his 25-year-old granddaughter wants to donate. If they entered a registry, he could get a kidney from someone closer to his age, while his granddaughter could donate to a younger person, who will then have a longer time to be able to benefit from receiving a kidney from a young donor. People can also enter the registry in search of a better genetic match. As we mentioned earlier, we know that perfectly matched kidneys have a longer lifespan. As can be seen in this graphic on the far right, a perfect matched living donor kidney lasts an average of 10 years longer than a less well-matched kidney. There are several steps that you must take in order to be added to the transplant waiting list. During today's evaluation visit, you went through registration, where we collect important information from you and give you a packet of materials about transplantation. During the course of the evaluation process, you will meet with several doctors, a kidney doctor and a transplant surgeon. These doctors will evaluate your health and suitability for transplantation. You will also meet with a social worker who will address your support system, any mental health or substance abuse issues, as well as insurance and financial aspects of transplantation. Your transplant coordinator is your main contact throughout the process, as they coordinate not only your transplant evaluation, but also maintaining you on the waiting list. A financial coordinator will also review your insurance and financial situation and counsel you about the costs associated with transplantation. Finally, you may be seen by a dietitian if it is determined that you could benefit from a nutritional consultation. Your attendance at this educational session is also an important part of this evaluation visit. There is a comprehensive panel of blood tests that are performed prior to determining your suitability for transplant. These include both standard laboratory tests as well as tests to determine blood type and cross-match compatibility. The standard tests include blood chemistry and hematology, as well as tests to look for infections such as HIV, hepatitis B and hepatitis C, and tuberculosis. All patients will need a chest X-ray and an electrocardiogram, also known as an EKG. Patients will also require either an abdominal ultrasound or CT scan. There will also be other testing required based on your gender, such as mammograms and pap smears for women and PSA levels for men, or your age, such as colonoscopy. In addition, your transplant coordinator will assist you in scheduling any other tests deemed necessary during your evaluation. Additional testing is based on your past medical history, family history, and/or symptoms that you are experiencing. Examples of this may include visits with physicians who specialize in diseases of the heart, liver, lungs, blood vessels, and also mental health professionals. Once all of your required testing is complete and we have received the results, the transplant team will meet to review your case and determine whether or not you are a suitable candidate for transplantation. If you are a suitable candidate, you will be added to the national waiting list, which is maintained by UNOS, the United Network for Organ Sharing. You will receive a letter in the mail outlining your status and outlining your responsibilities as a transplant candidate. Communication with your transplant coordinator is key to your success in receiving a transplant. Every month, your dialysis unit should draw a blood sample and send it to our transplant lab. It is essential that we receive these samples because the samples are used to run cross-matches with potential donors that become available. It is essential that you keep your transplant coordinator up to date. This includes changes to your contact information, telling us when you are on vacation, and similar information. We need to know how to reach you when a kidney becomes available. You must also let your transplant coordinator know of any significant changes to your medical condition. For example, if you have a heart attack, undergo major surgery, are hospitalized for an infection, or are diagnosed with cancer, these are important events that you must inform us of. Any changes to your health insurance must also be reported to us immediately, as we will need to reassess your ability to afford transplantation. In addition, you must return to our transplant center at least every 2 years to be reevaluated and make sure you can stay on the waiting list. You should also be aware of your right to list at multiple transplant centers and to transfer your waiting time. For multi-listing, you have the right to be listed at transplant centers in multiple geographic regions. It is not beneficial to list at more than one local center since we share the same pool of donor organs. If you are already listed for transplantation, you have the right to transfer that waiting time to another transplant center if you so choose. When transferring your waiting time, you do not lose any of the time you have already accumulated. As mentioned earlier, UNOS is the national organization that coordinates the distribution of organs for transplantation. Each time a donor becomes available, a computer searches the people on the waiting list to find the most appropriate recipients. Several factors determine who gets the transplant. These include the blood type of the donor and the recipient, the amount of waiting time that the person waiting has, the antigen match of the transplant, and ensuring that the cross-match between the donor and recipient is negative. When a potential organ becomes available, you will receive a call from a transplant coordinator who will make sure you are willing and able to come in for the transplant and are well enough. The transplant coordinator will provide you with important information, such as when you need to stop eating and drinking in preparation for surgery, and when you should come to the hospital. Keep in mind that being admitted to the hospital does not guarantee that you will receive a transplant. It is possible that the organ could go to someone higher up on the list at another center, or you could have a positive cross-match against the donor, which would prevent the transplant from occurring. When you are admitted to the hospital, you will have preoperative testing including blood draws for lab tests, an electrocardiogram, and a chest x-ray. You will be seen by several members of the transplant team who will make sure you are still healthy enough to undergo the transplant. Once it is confirmed that the transplant will proceed, you will receive several medications shortly before you are transferred to the operating room. The operation itself will take about 2 to 4 hours, and as you can see, an incision is made in your lower abdomen. The kidney is placed in the lower abdomen, below where your native kidneys sit. Once the surgery is over, you will be transferred to the recovery room, where you will remain for about 6 to 12 hours, after which you are moved to the transplant floor. Kidney transplant recipients are generally in the hospital for 4 to 6 days. During the hospital stay, you will have several intravenous lines so that we can administer medications and fluids to you. You will also have a Foley catheter for about 4 days. The purpose of the Foley catheter is to allow the urine to continuously drain from your body, giving your bladder some time to heal from the surgery. This also helps us to measure the amount of urine you are making, which tells us how well your kidney is working. In the first day after your surgery, your diet will be advanced to a clear liquid diet and then to solid food as long as you are tolerating it. You will need to get out of bed and walk in the first day as well. This helps to speed your recovery as well as prevent complications such as blood clots and pneumonia. You will learn about your medications and other important facts about how to care for yourself and your new kidney during various educational sessions while you are hospitalized. We know there are both risks and benefits associated with kidney transplantation. In terms of the transplant surgery itself, the risks are similar to any operation that requires general anesthesia. The main risks include pain from the operation, bleeding, blood clots, reaction to the anesthesia, and infections such as pneumonia or wound infection. For patients receiving a deceased donor kidney, there is a 30 to 40% chance that the kidney will not wake up right away. This is called delayed graft function. If this occurs, you will require dialysis until the kidney wakes up. Although it is rare, sometimes the kidney never wakes up. In this case, you will require dialysis and may go back on the list to wait for another transplant. In these cases, you get all of your prior waiting time back. Kidney transplant recipients sometimes develop depression or anxiety after their transplant. The medications we use to protect against rejection have short and long-term side effects. Each of the medications has a unique set of side effects that you will learn more about after your transplant. Because these medications affect the immune system, whose normal job is to protect us from infection and cancer, risks of these medications do include infection and cancer. We try to avoid these complications by tailoring each patient's medication regimen to provide an amount of immunosuppression that is effective yet minimizes side effects. Changes to insurance policies or jobs require careful consideration after transplant, since the medications and follow-up care can be expensive. Your recovery period may affect your finances due to increased child care costs, transportation costs, and lost wages. It is also very important to understand that transplanted organs do not last forever, and repeat transplantation is often necessary, particularly for people whose first transplant occurred at a younger age. Therefore, it is very important to stick to your medication and follow-up regimen to take care of your transplant so you can keep it working for as long as possible. Now that we reviewed the risks of kidney transplant, let's take a look at the benefits. Kidney transplantation is associated with a big improvement in quality of life compared to remaining on dialysis. This is due to freedom from dialysis treatments, a less restricted diet once the kidney is functioning well, and an overall improved sense of well-being. Transplant recipients often comment about feeling better very quickly after their transplant, even though they just had surgery. A very important benefit is that patient survival is much improved after transplant as compared to remaining on dialysis. There is only one alternative to kidney transplantation, which is to remain on dialysis. There are several types of medications that you need to take after having a transplant. The first type are immunosuppressants, also known as anti-rejection medications. These suppress your immune system in order to protect the transplanted organ from being rejected. As we mentioned earlier, we try to minimize the amount of immunosuppression to levels that prevent rejection while also minimizing side effects. This is our less is more philosophy. While you are in the hospital, you will receive several of these medications intravenously to give you a higher initial level of anti-rejection activity. These are called induction immunosuppressants. At the same time, you will also begin to receive other anti-rejection medications by mouth. These are the maintenance anti-rejection medications that you will continue to take for as long as your transplant continues to function. The most common maintenance immunosuppressants used at our transplant center are tacrolimus, also known as Prograf, and mycophenolic acid, also known as Myfortic. About 10 to 15% of patients will also require prednisone as part of their maintenance regimen. Reasons for needing prednisone include taking it before transplant, higher risk of rejection, and getting a pancreas transplant. Other types of medications you will take after transplant are medications that prevent infection. These are required since the anti-rejection medications needed to protect the transplant may increase your risk of infection. Therefore, you will need to take 3 medications for varying periods of time after your transplant. The first is called sulfamethoxazole trimethoprim, or Bactrim, which protects you against bacterial infection. It is taken for 1 year after your transplant. Next is valganciclovir, or Valcite, which helps to prevent viral infection. This is taken for 6 months after your transplant. Last is clotrimazole, or Miselex, which protects against fungal infection and is taken for 3 months after your transplant. The last group of medications you will take help to prevent some of the side effects of other medications, including a medication to prevent constipation and a blood pressure medication that has beneficial effects on your kidney function. In addition, we will tell you which, if any, of your pre-transplant medications need to be continued after transplant. Often, these may be medications used to treat high blood pressure, high cholesterol, or diabetes. It is very important for you to come to the transplant center for follow-up visits after your transplant. For the first month, you will need to visit us twice a week, or potentially more often if you have any complications. Then, for the next 2 months, you will visit us once a week. At 3 months, you may return to the care of your local kidney doctor. However, you also need to return to us for visits periodically, as you can see in the table. It is important to return to our center periodically so we can help you maintain your transplant for as long as possible. In general, transplant patients can return to work about 3 months after their transplant, as long as they are doing well. Now we would like to tell you a few things about our kidney transplant program. Our transplant program is the oldest in New York City, having performed New York's first kidney transplant in 1963. We are a Medicare-approved transplant center, and as you can see in the graphic on the right, Our program has performed more than 200 kidney transplants every year since 2006. You will see in the next few minutes that the kidney transplant outcomes at our transplant program are the best in the region. We are the only program whose outcomes are better than expected. The mission of our transplant program is to maximize opportunities for transplantation for all of our patients. If there is a way to safely transplant you, we will find it. As we just mentioned, our transplant program is the only one in the region to have outcomes that are better than expected based on the types of transplants we perform and the complexity of the patients we transplant. In the graphic on the left, you can see that patient survival at 3 years after transplant is significantly better than expected at Weill Cornell. The 3-year patient survival at our center is 94.1%, which is significantly higher than the expected survival of 90.8%. On the right, you can see that our 3-year kidney graft survival is also significantly better than expected, 86.4% at Cornell compared to an expected value of 81.8%. We are very proud that we not only achieve our mission to get patients transplanted, but also provide them with innovative care that provides excellent outcomes for both the patient and their kidney alike. Thanks to the innovative programs that we have implemented at Weill Cornell, we have shorter waiting times than other transplant centers, both locally and nationally. The graphic on the left shows the percent of patients on the deceased donor list who have been transplanted by 3 years on the waiting list. For blood types A, AB, and O, our transplant program has higher transplant rates compared to all centers nationally. By 3 years, 57% of patients with blood type A have been transplanted, 15% of those with blood type B, 82% of patients with blood type AB, and 32% of patients with blood type O. On the right, you can see that the time at which half of patients on our waiting list would receive a transplant is 34 months, shorter than the New York area, the region, and the United States, where the time is 70, 58, and 49 months, respectively. It is important to note that these times include both living and deceased donor recipients, and the fact that we perform so many living donor kidney transplants at Weill Cornell may bring down our time. We would like to highlight a few other points about our transplant program that may be of interest to you. Our program consists of a dedicated, experienced group of professionals with many years in the field of transplantation that cares for a large group of transplant patients. This large group of patients is very diverse, all ages, from the very young to the elderly, all races, and patients of varying medical conditions besides their kidney disease. We have been able to personalize and minimize the immunosuppression regimen of our patients and have a 10-year history of cutting-edge immune therapy with the steroid-free maintenance immunosuppression regimen. Our transplant program is housed within New York Presbyterian, the #1 hospital in New York, #6 in the nation, and the #4 Center for Kidney Disease in the United States. In addition, we have a very active research program in both the research lab and at the bedside of our patients. Some of the most exciting research surrounds development of a non-invasive monitoring test for rejection that may someday replace the need for a kidney biopsy. We also have one of the largest experiences with kidney-paired donation, which enables transplantation for patients who might otherwise wait a long time on the waiting list for a deceased donor kidney transplant. Also in the arena of living donation, our donor surgeon has the largest national experience with single-site surgery for removing the donor's kidney, which uses just one incision around the belly button to perform the laparoscopic surgery and remove the kidney. As a result of all of the factors listed above, We are proud to have amongst the shortest waiting times in the New York region while maintaining the best outcomes in the region. Thank you for your attention to this important educational program. We hope you found it to be informative and useful in your decision to pursue transplantation. Please direct any questions to your transplant coordinator or other team members that you meet today. We ask that patients being evaluated for pancreas transplantation to remain in the room to view several additional slides that will supplement what you have just learned. Everyone who has completed their viewing of this program may return to the clinic waiting area. Thank you again for your participation. Thank you for staying a few more minutes to learn about pancreas transplantation. This information will supplement what you have just learned in the general session. People with type 1 diabetes, also known as juvenile or autoimmune diabetes, are eligible for a pancreas transplant if they meet certain criteria. The first is kidney failure requiring dialysis or transplant. These patients could be eligible to be listed for both a kidney and a pancreas if they have kidney failure. The second is for patients who have a prior kidney transplant that is functioning well. The third is for patients who do not have kidney problems or a prior kidney transplant, but do have difficulty managing blood sugar levels despite their best efforts. They may also have hypoglycemic unawareness, a dangerous complication of diabetes where the person no longer experiences the classic symptoms of hypoglycemia, such as shaking, sweating, or rapid heartbeat. Based on the criteria just mentioned, patients with type 1 diabetes may be eligible for one of three types of pancreas transplant. If the patient has kidney failure and needs a transplant, they could consider having a simultaneous pancreas kidney transplant where one deceased donor provides both organs. For patients that have already had a kidney transplant and it is functioning well, a pancreas after kidney transplant can be considered if they experience hypoglycemic unawareness or other inability to control their diabetes. Lastly, patients may qualify for a solitary pancreas transplant if they have good kidney function with no prior transplant and need a pancreas transplant due to hypoglycemic unawareness. The risks of pancreas transplantation are similar to what we discussed for kidney transplantation in terms of the risks of surgery, anesthesia, and postoperative complications. Pancreas transplant patients do have a higher risk of developing blood clots within the pancreas, so patients receive aspirin as a blood thinner after the transplant. It is also possible that the pancreas may not work immediately, and the recipient will continue to require insulin injections for a period of time. Rarely, the pancreas will never work, and the patient will continue to require insulin unless they receive a successful transplant in the future. The risks after pancreas transplant are also very similar to those after kidney transplantation, which we have just reviewed. Similar to kidneys, transplanted pancreases do not last forever, and the patient will likely need to go back on insulin and/or have another transplant in the future. The main benefit of pancreas transplantation is improved quality of life due to freedom from insulin injections and from dialysis in the cases of a simultaneous kidney pancreas transplant. Having normal blood glucose levels can prevent the development or worsening of diabetes complications affecting the eyes, nerves, kidneys, heart, and blood vessels. Good blood glucose control can help protect a kidney transplant from the complications of diabetes. The ability to sense hypoglycemic symptoms is also typically restored by pancreas transplantation, and patients who receive a kidney and pancreas transplant have improved survival compared to those who receive just a kidney. The only alternative to pancreas transplantation is to remain on insulin, either through subcutaneous injections or an insulin pump. There are also continuous glucose monitoring systems which can provide additional monitoring tools for patients, particularly those with hypoglycemic unawareness. When you are admitted to the hospital, you will have preoperative testing, including blood draws for laboratory tests, an electrocardiogram, and a chest x-ray. You will be seen by several members of the transplant team who will make sure you are still healthy enough to undergo the transplant. Once it is confirmed that the transplant will proceed, you will receive several medications shortly before you are transferred to the operating room. The operation itself will take about 3 to 6 hours, and as you can see, an incision is made in the middle of the abdomen. The transplant pancreas is placed in the lower abdomen, where its blood vessels are connected to yours. Due to the digestive enzymes that the pancreas produces in addition to insulin, a part of the donor's small intestine is attached to your small intestine to allow these enzymes to drain. If you are also receiving a kidney at the same time, the kidney is placed on the opposite side of your abdomen, using the surgical technique described earlier. Once the surgery is over, you will be transferred to the surgical intensive care unit, where you will spend the first few days of your recovery. Pancreas transplant recipients are generally in the hospital for 6 to 8 days. During your hospital stay, you will have several intravenous lines so that we can administer medications and fluids. You will also have a Foley catheter for about 4 days. The purpose of the Foley catheter is to allow urine to continuously drain from your body, allowing the bladder time to heal if you had a simultaneous kidney transplant. The Foley catheter also helps us to measure the amount of urine you are making, which tells us how your kidney is working. Because the digestive enzyme drainage requires surgery on the small intestine, pancreas transplant recipients also have a nasogastric or NG tube for several days. During this time, the patient cannot eat, drink, or take medications by mouth. This gives the intestinal surgery time to heal. For the first 2 days, you will also need to lie flat to reduce the risk of clotting in the pancreas blood vessels. When your intestinal function recovers, the nasogastric tube will be removed and your diet will be advanced to a clear liquid diet at first, and then to solid food as long as you can tolerate it. You will begin to get out of bed and walk, and within a few days of your surgery. This helps to speed your recovery as well as prevent complications such as blood clots and pneumonia. You will learn about your medications and other important facts about how to care for yourself and your transplant during various education sessions while you are hospitalized. This concludes the additional education for pancreas transplant candidates. Thank you very much for your attention. Please return to the clinic waiting area for your next meeting.